Egunon denoi.
Good morning, everyone, or egunon, as we say in the Basque language. Thank you very much for coming. Now, I'm going to be talking about the program PAM, the program Care Plan for the Elderly, the PAM plan. It's been up and running since 2018, and it's headed up by a multidisciplinary team, and it's also reviewed by experts, has been reviewed by experts. I'm just going to try and get the right button here. Just to give you a bit of context, the WHO report on the aging process talked about healthy aging as the process of fostering and maintaining functional capacity, which will enable well-being during old age. Now, if we talk to elderly people, what they are most concerned about is how to maintain their functional capacity. But in order to maintain functional capacity, the WHO also said it's not enough to just do the same as we have been doing in the past. We need a systemic change. In relation to the aim of increasing functional capacity during old age and to prevent disability at a national level, in 2014, a consensus document on the prevention of fragility and falls among elderly people was approved, again in 2014. In the Basque country, we have our health plan, includes an intervention about how we have to set up a program, a care program for the elderly. And this is also referred to in the challenges and strategic projects of OSAKIDETZA, the Basque Health Service, and it also is referred to in the strategic priorities for the Basque Health and Social Services. So, to follow on from what I was saying about this change of paradigm, we have to move from a model which is basically based on diseases and curing them to a model which is based on integrated care focused around the elderly people themselves. This is what we're aiming to do through the PAM plan, the care plan for the elderly. Now, throughout the course of my talk, I will be talking about the PAM plan. She calls it the PAM plan, the care plan for the elderly. The aim of this plan is to increase functional capacity in people over the age of 70. In order to do that, we need a structured program. It's important to work between health professionals and social professionals to have a joint effort by both of them. The idea is to identify functional capacity at the beginning and to divide elderly people into different groups with regards to their functional capacity, then to carry out a multidimensional assessment according to the different groups in order to come up with a customized care plan, and then to establish interventions which will contribute to the maintenance of the functionality and quality of life of elderly people. Now, this plan can be expressed in this diagram that you can see on the screen. As I said before, at the beginning, there is an identification of the functionality level. There's a series of scales. I'm not going to go into detail with regard to the different scales, but if at the end of my talk somebody wants me to talk about them, you can always ask me a question. So there's a series of scales that we have identified. And these scales will define the category. There are 5 different types. There is somebody in robust health with comorbidities but no functional deterioration, fragile, dependent, or at end of life. And depending on these 5 categories, we will carry out a functional assessment in accordance with the category, of course. And then through this evaluation, we can determine a series of interventions to be carried out, which would, the working group at least, has set out or identified as priorities. So, for example, one series of interventions, which are in orange on the screen, and that is we have tried to integrate them with the interventions or programs which have already been carried out in OSAKIDETZA, the Basque Health Service. In OSAKIDETZA, there's a series of programs and projects that are already underway, and it's important to integrate what we do into these programs, because we wanted professionals practitioners to see elderly patients as elderly patients, to focus on them as people. And this is why we have made this effort to try to integrate everything that we do. Now, this is our flowchart for the interventions, for the multi-dimensional approach. We've taken different aspects of the geriatric evaluation, but we've tried to make it compatible at the same time with the care that is provided in primary care. So there's a functional evaluation, a mental health evaluation, evaluation of the carer, etc. And then in the preventive evaluation, we have the general evaluation as well. Which is an evaluation which has to do with weight and size, etc. There are some which are specifically related to geriatric syndromes, another with polymedication, and then looking at the comorbidity of these elderly people. In relation to all of this, we come up with therapeutic care and customized care plan as well. Now, to set it up, we carried out a pilot project which lasted for 6 months, carried out between the end of 2016 and the beginning of 2017. The aim was to assess the program in a controlled way in order to establish the different adjustments that we needed to make in order to guarantee its applicability and its subsequent deployment in primary care points. Now, this evaluation, this pilot project, was a research project, a study. It was carried out as a research study, and we assessed 1,200 people with a mean age of 79, and 85%. We were able to actually determine the category in 85% of cases. It was carried out in 7 health centres throughout the entire OSAKIDETZA network. Now, we had a specific structure for evaluating. I'm not going to explain it, but I would like to highlight the importance of measuring the impact pre and post intervention. And I identified the functional situation of each participant, which resulted in this pyramid, which is significant, especially in relation with the sample that we used. Now, this is the pyramid. It's like our population pyramid, really. We have those in robust health at the bottom, and then we go up until you get the ones at the end of life, in the end of life stage. Now, one thing that we can say is that systematizing the intervention has had a very positive impact with regard to assessing the points that you can see below. But even though many of the variables were in fact twice as high as we thought they were, according to official registers, there are some, such as the level of physical activity and falls, which are marked with an asterisk there, which should they need to be improved. The care and the registering of them needs to be, the reporting of them needs to be improved. Now, what to do with this assessment as well? This was another question. Now, in the centres involved in the pilot project, they said that we had to evaluate fewer people in order to improve the screening criteria as well. They also told us that we needed to have different specific forms to be filled in. And we have incorporated all of these suggestions into the new version of the program. And then another important aspect was that we needed to coordinate with other groups and programs. Now, this is something that I mentioned when we were looking at the flow chart. This is something that we try to do. We try to coordinate our efforts with other programs for the deployment and for the training as well. For the pilot project, we did have a training plan. And in the deployment of it throughout the entire service, we have aimed to improve on what we did in the pilot project. And we have developed a series of professional support tools. We have developed some care plans within the PAM. Now, we have two information systems, it's important to mention. We have the clinical histories, and we have them in the global service, and we also have them in the place where we called Los Anaya, which is where we have the central services of all the different information, and it's where the care plans are developed. So what we've tried to do is to set up tools and develop tools to try to standardize these tools in the different areas in which practitioners need to carry out the assessments. We've also, with the aim of training practitioners in relation to this plan for the elderly, we've set up an online training scheme as well. Computer formats have been adapted as well to all the different requirements of the plan. We have developed different forms for functional capacity evaluation as another form that we have developed for evaluating functional evaluation and alert systems for fragile patients. And we have provided different help sections so that it's easier for people to report incidents. We've also developed some educational material. And this material can be used by all practitioners in primary care points, and then also different documents, different resources which are available on the website, the intranet, and the extranet. So we have, there's the guidebook as well, and then there are different resources that all practitioners can use on the website. Now, we've only been up and running since April. It's not been April last year until now, and not for very long then. But we wanted to bring you today some data, some outcomes with regard to deployment, with regard to the training, evaluation, the categories, etc. With regard to training, the online PAM training, there you can see that despite the fact that the target group were in the primary care sector, we have also provided training to professionals working in other areas, in hospitals, in the emergency room, mental health, for example, who are interested in this particular, in the training provided by the plan. Now, the analysis was carried out in the primary care sector, and there were 732 people who were registered. Only 60-odd% were actually deemed apt. Now we are going to evaluate what sort of resources we're going to be using in the future, how we can make things easier so that we can improve the course itself. So I'm being told I've been taking up too much time. Because in the reviews, they've been told that there's too many videos. It's quite a burden. So 23% of participants were nursing staff, and the rest were physicians. If we have a look at the categories, you can see that it's not very even results. So we can say that the deployment is not an even deployment. We've also identified the categories in accordance with the organisation of services, and this is really going to help us when we're deploying it more. If we compare this with the population pyramid that we saw at the beginning, we can see that, as expected, if we compare it with what was expected and what was actually observed, we can see that the patients that are being included in the deployment are more complex patients. They're more dependent, more towards the end of life. And we have a hypothesis which says that there will be chronic patients receiving home care, and we need to start with them. With regard to the different drugs that are being taken, you can see that a very high percentage of polymedication, taking more than 10 different drugs. I don't know if I have time to look at this. Well, if you look here, you can see that all the different categories and all the patients if we compare these with the over 60s population, general population, you can see that polymedicated patients there's a much higher percentage of them among our participants. Now, we have to carry out a scoreboard, for example. We haven't been able to fill it with data yet, the scorecard, sorry, but we will do that in the future. And for future challenges, well, we have a group which is focusing on physical activity among the elderly. It's a multi-professional, multi-area, multi-departmental group, a working team from the University of the Basque Country, from the different provincial councils. We also have people from OSAKIDETZA, the Public Health Service, and these are the actions that we will be prioritizing in the future to have sort of training pills, basic short training courses for people. Now, I'm just going to read this very, very quickly, although we can't really see it up here on the screen. But it seems that the project helps us to improve the health and social support. The aim is to maintain their functional level. We are better able to identify situations of fragility, to monitor health problems and their complications, and it makes coordination easier, and it helps us to integrate the program with other programs that are currently up and running, provided by the Basque government. The deployment is not very even, and we need to adapt the training to each particular field and to look at the dropout rate as well. We believe that the scorecard in the future will enable us to understand people's functional situation better and how suitable the interventions are. And this will enable us to adapt the program accordingly. But this is everybody's responsibility. It's our responsibility to build a better aging for all of us, and we think that the PAM plan will help us do just that. And I'm sorry if I have talked for too long. Thank you very much.
Muchísimas gracias, María.